Okay. Good day, everyone, and I'm very happy to see you again. Hope that everything looks fine, and I'm really enjoying your meeting here. Today we will talk about approaches and the principle of alignment in total knee. This is the third webinar in the series of a principle in total knee surgery. Um, I think if anyone had a question, you can write it immediately, because this lecture, I think, is a little bit long than ever. And we will start to make as we uh, as we know that the webinar schedule, starting at biomechanics, we spoke about the indication and total knee arthroplasty preoperative management, and the approaches and techniques today. So anyone has a question, you can write it in the chat, and at the end of this lecture, I will answer it happily. And anyone have another answer, I'm happy to listen to his share ideas. Thank you very much for your attending, and we will start, inshallah, soon. As a beginning of this lecture, we have some learning objectives. The first of all is that the common use of the approach is the medial parapatellar approach. ولهذا احنا حنركز به اكثر ان شاء الله اليوم اكثر من باقي الابروتشز. And we are specifically talking about the primary total knee approach only, not the revision, because revision have another, the medial parapatellar approach and the extensile approaches later. There are some tips and tricks using the retractors during the parapatellar approach, and we will start to apply the templating and alignment during the surgery, and what we are called about some codes that we will so we will see that later, how to apply it in the during surgery. It is not a surgical technique actually, because the surgical technique حطيتها بالمحاضرة اللي بعدها إن شاء الله. So about the exposure of the total knee, we know that there are many approaches in the total knee, and all of them have the same goal and the same principle. Because of the knee have devoted of many muscular supply, and that's why it contains only the three main layers, which are the skin capsule اللي هو الارثروتومي، وبعدين الكوادريسبس تندن. والكوادريسبس تندن هو النيم، هو الاسم اللي احنا اللي حنشوفه whether it is medial parapatellar or other names that are varied of exposure in the total knee. هذا مخطط بسيط. This schedule shows the approaches of the knee either in the regarding the capsule. نبديها من ناحية lateral arthrotomy approach, which is used by many surgeons during valgus and severe valgus, and medial parapatellar approach. الميديال parapatellar هنا في حالة الكبسول. من بعد الكبسول اللي حيكون الابروتش اللي حيتسمى according to the quadriceps tendon incision, either MIS or non-MIS. The MIS means that the minimal invasive surgical technique, not only the skin, they are minimally invasive, and we will see why it's named like that. The non-MIS واللي هو احنا نعرفه medial parapatellar approach, we will see this schedule here regarding the skin, capsule, the quadriceps, how to take it up into 1/3 and 2/3, and what are the standard and variation in the presence of a scar. Okay, regarding the medial parapatellar approach, it's first first in 1879, the surgeon von Lengebeck has used this approach in the knee, and he saw that it is reliable, safe, and easily visualize everything in the compartments of the knee and access to all structures inside the knee joint. And it's only have concern about the violation of the extensor mechanism, and we will see what are the difference between this approach and other approaches. The MIS approaches, as we said, it is less than 5 inches in length of the skin, but they are divided into subvastus, midvastus, and trivector, and what we call the quadriceps snip. Otherwise, a quadriceps snip is يعني هو extensile approach, and some of the surgeons prefer it in a severely deformed knee in a revision type. There are subfacial dissection only. يعني the skin, when you start it from a midline, and then you go on the subfacial immediately without making a big flaps. Because of that, the knee, and because of precarious blood supply, because of the precarious blood supply, you can see that the major blood supply of the knee joint around the knee is about the medial superior and medial inferior geniculate arteries, and also the lateral superior and lateral inferior geniculate arteries. So that's why we are going in through the midline only to minimize the blood supply. And because of that, there are many, as in review of literature, shows that many signs, many risk factor that causing the surgical site infection, as you see in this notes. The anterior midline with the medial parapatellar approach, as we see that in flexion of the knee in 70 degrees, we start to prep the skin and prepare the and drape all the body, and only the affected knee we will start to have this approach. Before that, we will start to make the landmarks, the tibial tubercle or tuberosity, and the inferior pole of the patella and the center of the patella, as well as on both medial and lateral joint line. This is difficult when we see, or when we are you are operating an obese patient, and so that in obese patient you have to be sure about the preoperative methods and the preoperative notes, how to palpate the tibial tuberosity, especially in those with obese with varus, severe varus knee. Be careful about that. So I will talk later about some tricks and principle on during the operation, how to put the tourniquet and put the side supports in the knee, because it is very crucial. Together, we will have a well positioned of the lower limb during a total knee replacement. So the main part of what we are called the anterior midline has the least destruction of the blood supply, as we see in the previous picture, how the blood supply is now have the least of the total knee in both flaps. Okay. The previous surgery, if you have a previous surgery, use the same incision, the same midline. Whether there are many surgeries that are causing short one, you can ignore it. You can ignore it, okay? You can ignore the short one and you start for midline incision. Otherwise, if you have a same incision, go for it immediately. A transverse incision, if there are some transverse incision, as many we know in the previously, some or formerly they do meniscectomy via open technique, and you can do a perpendicular incision on that one, or at 60 degree if it is an oblique one. If there are more than one incision, do the most lateral, because there are the infralateral part of the infrapatellar nerve to be not injured. Also, if there are many incisions, Mont suggested that the midline incision should be at 8 cm, Ranawat suggested that 5 cm distance, and Rand suggested at least 2.5 cm distance from your incision from other incisions, because in order to save the pedicle of the flap between both incisions. So what about extension? Now you start incising with your blade, and now you can avoid first short incision, as we see, and there will be an excessive traction. Do not do that, because short incision, is there clear? Okay. Short incisions, you may have to interfere with a jig. Sorry. Short incisions, if you do a midline incision, you can put a jig or retractors, or sometimes you have to do an excessive traction. And this is forbidden during the surgery. You must have at ease with your sorry. I'm sorry for this interruption. So avoid shorter incision in order not to be there are excessive traction. Okay, and let's go on. Proximally 5 cm. You start the incision from the inferior pole of the patella or the center of the patella into the tibial tubercle. This is the main one, but you have to do it more proximal in order to access the distal femur. So you can do approximately 5 to 7 cm. Some surgeons prefer a shorter extension proximally, and they respectively, as they want, they increase the proximal distance. Distally, this is a very important thing. Scuderi found that to avoid the U sign and to get the V sign. What are these? If you got a smaller distal extension, and you will see in the left picture, like the U shape, there is a letter U, but here in the skin. But here you can see if you do longer one, you will see a V shape. That's why there is no tenting over the soft tissue and the skin as well. Be very precarious because of a precarious blood supply in the distal part of the skin as well. So this is very important during the incision. How about the deep dissection? Now, points to identify first is that the medial margin of the patella, as you see in this picture, and the second one is that the patellar tendon and tibial tubercle, which is most distally, and then you can go proximally with the gauze dissection. You have to be sure about the central part and the central whitish tendon of the quadriceps. Mark it with a pen in order when you have to repair it, no dog ear, because this will cause an extension lag. And that's why in many articles in previously, they suggested that the medial parapatellar incision has the violation, not cut, no injury, violation only of the extensor mechanism more than other MIS, because the MIS, like quadriceps snip or the subvastus approach, they do not violate the quadriceps tendon. But here in the if you do a proper suturing, a proper when you mark it first, no dog ear, there will be no extensor lag. As you can see, we will start the incision of the quadriceps tendon between the medial 1/3 and the lateral 2/3 of the tendon. Not in the center, not on the flesh of the vastus medialis. Leave at least 5 millimeter of the retinacular when you are going down, 5 millimeter of the retinacular, and the medial attachment with that of the patella in order to suture it again after you close it. Flex the knee usually in 60 to 70 degree. Blade angle when you are doing the arthrotomy is 30 degree from the midline of the knee joint. And curve it then laterally down to the anterior cortex of the tibia, and then 5 millimeter medial to the tibial tuberosity, and you end this part. I hope that you all you have a clear in listening. So please, may I beg you to do mute for your voices. Thank you very much for your attending again. Okay, the parapatellar now incision has been completed. The patella either retracted or everted. Some of surgeons, they prefer this, some and others, they prefer that. There are no difference, but many literature suggested that in the deep dissection, they suggested that the patellar eversion is better. Okay, the anterior and let's to say the posterior horn of medial meniscus is now can be excised. You have to see that the anterior horn of the medial meniscus and you excise it. The sleeve between the medial meniscus soft tissue is released. According to a proper preoperative deformity, if you have a deformity that is severe, you can go for between the meniscocapsular ligament and you excise it. And then into the posteromedial and superosteally too. During this, you can do it with a scalpel. A Hohmann retractor is now placed between the capsulomeniscus portion that you can see it, and we will see it in the picture, to protect the medial collateral ligament. Any intermedial osteophyte should be removed, and now you can sever and cut the ACL when it is intact. You can hyperflex the tibia and external rotate it. During external rotation, you decrease the tension on the tibial and the patellar tendon, and also to see the whole proximal patella. Here you can see the in the lateral compartment, the fat pad excision and non-excising versus non-excising. When you have to do an flexion of the knee and the patella is very difficult to be retracted, you have to evert it. So an extension of the knee, you can do elevation of the patella and go for the fat pad, the fat pad, whether it is excised or not, I will talk it later. You can see that the patella cannot be everted easily, so you can do the lateral patellofemoral ligament release with the knife, very small knife, inside knife. You can do it in extension of the knee. You elevate the patella and you excised a little bit for the lateral patellofemoral ligament. As you see it here in this picture, you can see how the patellofemoral ligament is now trying to be excised. After that, you do an eversion of the patella and then flexion of the knee.
Microphone is muted. Your video is stopped. When tap to speak.
So again, after that, you have now a well informative and everted knee. But if you can see that the patellar fat excision versus non-excising the fat pad on the patellar tendon, this is also a dilemma. Some of the surgeons suggested that you cannot remove every fat pad because this will cause an anterior knee pain after surgery. Some of them suggested that you excise it and you leave the inferior part of the portion of that with the patellar tendon. Okay, there is no significant effect when the patellar tendon contracture regarding the fat pad excision, range of motion, and the knee society score. 4.2% of the patellar tendon is shortening in one of the literature, as you see it in 2007, to 4.2 patellar tendon shortening, and this is the that's why they leave without excision. They leave the fat pad. Okay, whether everting or not, as we see, some of the surgeons suggested that you evert it, and some are using retraction only. This depends on your experience. How about the lateral again? So before excision of the lateral meniscus, make 1.5 or 2 centimeter incision just lateral to the lateral meniscus space. In the small Hohmann retractor, what we call it, أو إحنا نسميه السبايك هناك اللي حتخليه. Then proceed the excision with the protection of the LCL. You have to be precise in that. You can see here, I put the Kocher in the anterior horn of the lateral meniscus, and this is the human which is vertical. دائما اسأل اطلب من الاسيستنت انه يخلي vertical one and the small one in this area. This is the incision. As you can see, the LCL is now protected, and the what here is holding is the fat pad with the patellar tendon. Okay, and this is the femur, this is the tibia. You can see here this lumen of the lateral inferior geniculate artery. You now can, before this, you can coagulate and then proceed with excision of the lateral meniscus. دائما خلي الاسيستنت مالتك يخلي السبايك او اللي احنا نسميه عادة human retractor, small human, not push it with force. Use only 2 fingers in order to protect both the patellar tendon and the LCL. Otherwise, if you do force, there will be rupture of the extensor mechanism and or the LCL. So the MIS technique for the primary total knee arthroplasty is regarding that. This is the medial parapatellar ligament, and this is the final picture you want to see. This is the knee joint with arthritis, and arthritic changes has got in the mid-substance tier of the ACL, as well as you can see the spikes in the medial here, and the lateral is there. And you can see now, pointing with the electrodiathermy, the LCL is intact, okay? And this is the patellar tendon. That's what we all share about this. The subvastus, midvastus, and vastus and quadriceps sparing, these are all minimal invasive technique. Why minimal invasive? Because it does not form, it does not violate the extensor mechanism. What are the difference between each? They all share in one theory. They all share that we reduce the blood supply, we reduce the risk of violation of a blood supply in the patella, and hence reduce the anterior knee pain. The other thing is that early physical therapy, early motion, this is true. And the third thing is that a powerful extensor mechanism due to not like that of the medial parapatellar incision, which we are going to incise it. However, in recent literature, they suggested first to be sure about the blood loss. It is less when we are using tranexamic acid, وهو هذا اللي رح نتكلم عنه إن شاء الله في محاضرات أخرى. رح يكون إنه الإكستنسر ميكانيزم العفو البلود لوس رح يكون يقل when we are using intraoperative tranexamic acid. The second thing is that the new modification of the physical therapy, the rehabilitation system after total knee in the primary total knee using medial parapatellar approach, they have the same result, knee society score and early rehabilitation as a function when in the comparison with other MIS technique. So that's why many surgeons have reduced the use of the MIS technique. فمجرد للعلم احنا حطيناها حتى نعرف انه الفاستس subvastus approach and vastus sparing and midvastus approach. Subvastus approach, some of the surgeons they use it in valgus knee, especially when you have a valgus less than 15 degrees. Okay, and if you go with a very effective and experienced surgeon to do a subvastus or midvastus, and you have got tight or inability to put your jigs or the access of the knee is very difficult, try to convert it into medial parapatellar approach. So if you have got a question, I will receive it before the part 2 of alignment. We will start. They are coming again. Everything is okay. الصوت الصورة تمام. Okay. Let's see in part 2 regarding the alignment. أرجو أن يكون الصوت mute position. Thank you very much. Okay, what about the alignment of the total knee? The concept of the total knee, when we are talking about total knee replacement and we want to do it in a successful way, there are 4 principal things you have to think about. The first is that the alignment, and second, kinematics, fixation of the total knee and stability. اللي رح نتحدث عنه هو اليوم عن ال alignment، وتحدثنا عن الكاينماتكس في المحاضرة اللي قبلها، وكان موضوعنا عن التمبليتنج أيضا بعد الكاينماتكس. رح نطبق بعض الأمور على التمبليتنج with the alignment for the fixation and the stability and gap balance والligaments رح نتحدث بها بالoperative technique إن شاء الله. So the goals of total knee replacement is that restoration of the mechanical axis first, and we will talk what is the mechanical axis, to reserve and preserve the joint line, the balancing of the ligament and soft tissue, especially using the gap balance, because we know that the total knee is a soft tissue surgery balancing in the use of bony cuts. It's not only bony cut, it's balancing the soft tissue by and via the bony cut. This will be in the next webinar. دائما ممكن أنه we forget this joint, which is the Patellofemoral Joint, and how about its tracking. All of these four important things, these are not optional. These must be used, all of them, for during the surgery. So we can apply it either in the coronal, no, sorry, not either, all of them in coronal, rotational, sagittal plane, in both femur and tibia. One of the Egyptian surgeon, thankfully, Dr. Mahmoud Abdel Karim, one of the best surgeon, he has a code in the total knee. يعني شلون واحد عنده فت قفل ودا يريد يفتحها. الكود هو 637. This code have to be remembered well. Okay? We will see what are these codes referred to. First of the alignment, now we will talk about the coronal alignment of the total knee. First of all, you know that the mechanical axis of the standing at ease in the body start from the center of the hip to the center of the ankle, and you will see how to estimate the centers. If you have got the center from the hip and the ankle passing through the mid-third of the knee, this is normal alignment in coronal plane. If this angle, the mechanical axis هو اللي هذا سميناه احنا mechanical axis، إذا كان on the medial side, this is varus mechanical axis, or valgus إذا كان هو mechanical axis away on the lateral side of the lower limb. شافوا أنه إحنا هذا mechanical axis from the vertical axis of the body, it forms a 3-degree valgus angle. What about the femur itself? The femur has an anatomical axis and a mechanical axis, differs. The anatomical axis, as you see, if you got a point here, 2 points in the mid shafts below the lesser trochanter, below the lesser trochanter, here we have 2 points. Are you good? You listen to me? الصوت واضح اخوان؟ اوكي. 2 points، وحده هنا وحده هنا وحده هنا وحده هنا. The distance between them are 10 centimeters, where you center these 2 points and center these 2 points, and then you form a one straight line. اخوان تسمعوني زين؟ اوكي. This line is formed that the femoral shaft axis, or what we call the anatomical axis. And here we have the mechanical axis from the center of the hip to the center of the knee. As you can see in the other picture, that the angle between mechanical and anatomical axis is 5 to 7 degrees. This is the anatomical axis of the femur, and this is the mechanical axis of the body. And usually you can see, and we will see later, the distal femoral resection perpendicular to its mechanical axis, not the anatomical axis, and you see why. So it is important to assess the rotation of the leg on a scanogram before considering the angle of resection, because any external rotation of the leg will abnormally indicate a higher resection angle due to femoral bowing, and this is easily judged by assessing the position of the patella. As you can see, the patella must be faced forward in the AP view. This is an AP view standing of a patient with a varus knee bilateral varus thrust gait. And you can see that how will we estimate the femoral center. First of all, some of the goniometers have circle, and you can put the circle and then it has a center. وإذا ما عندك أنت الgoniometer, simply you can add this one. How? Because you can see, this is the التخطيط هذا. بالنسبة لهذا التخطيط خلينا نكبره هي شكل اوكي. إذا تلاحظ هنا ال outer border of the acetabulum and the femur. One of the principle in assessing the hip center of rotation, as in total hip webinars, you can have the length of the hip of the head of the femur هذا كله، وبعدين وراها تاخذ ال medial most point to the junction of the head and neck. من لحا يتقاطعون ذول اثنيناتهم اللي حيكون هذا السنتر of the hip. من هذا السنتر للهب احنا اذا نشوف هذا الخط اللي راح نستعمله هو نفس هذا الميكانيكال axis of the body. This is the mechanical axis from the center of the hip to the center of the ankle. So how about the ankle? The ankle is simply اذا شفنا لي جوا انه this point is the center of the talar dome. This is the simplest way. There are others, like for example the lateral border of the malleolus and the medial border of the medial malleolus. Another point is that the medial border of the lateral malleolus and the lateral border of the medial malleolus بالعكس. فالمهم هي أكثر من reference حتى نتأكد من النقطة وين بالضبط تصير. The center, the mechanical axis now can be drawn. Also, in the distal femur, you can have the center of the knee joint. In distal femur, you can have the medial and lateral epicondyle, and it is centered here. From this center, now we have the mechanical axis of the femur اللي هو رقم 2. هذا number 1, and this is number 2. Number 1, the mechanical axis of the body. Again, from the center of the hip to the center of the ankle. This is simple, but what we are applied for. And you can see here the anatomical axis, number 3, these 2 points distant from 10 centimeters, and they are joined in this line. So what about this angle? This angle, number 1, in the Latin is formed the intramedullary canal angle. Okay. The cut of the distal femur will be perpendicular to the mechanical axis of the femur, not anatomic. In order to have a rectangular, well situated loads, because the loads of the body will be even if you have cut the distal femur on perpendicular on the mechanical axis, in order to distribute the load well. Okay. Regarding the tibia, we will see how the mechanical and anatomical axes are parallel. Okay, 6 degree رقم 1 اللي هو اللي حيكون عندنا رقم 6 اللي هو قلنا بالكود 6 degree of valgus cut of the distal femur. And this is why we are asking your colleague of the company to put the distal femoral cut in 6 degree. 3 degrees, if you see it, in it is varus, and 6 degrees is perpendicular to the mechanical axis, as you see in this picture, and 9 degree will be varus. So to improve the load distribution of the limb, as we said, to the joint and implant, make the distal cut perpendicular to the mechanical axis. It is 5 to 7. فإحنا ناخذ المعدل الأفرج مالتهم it is 6. The anatomical axis in both AP and lateral view will be determined the entry point of the intramedullary guide wire, and we will see later in the few moments. With the distal device, you choose 6 degree of valgus angle, must be perpendicular ونعيدها مرة الأخرى على الأكسس of the femur. But is it true for every patient? No. Tall persons, إذا احنا نشوف هاي المعادلة, tall persons who are 6 feet 5 inches اللي هم خلينا نقول بالسنتيمتر 195 سنتيمتر, you take the angle cut into 4. and vice versa بالنسبة للshort. Short persons who are less than 5 inches اللي احنا نسميهم less than 143 centimeters, you can choose a higher up to 8 degrees. So how much should I cut? هسه احنا عرفنا أول قصة اللي هي valgus cut angle must be 6 degrees and must be perpendicular. So how much I take from the distal femur? To prepare the distal femur, you have to take much more than 9 millimeter from the medial joint line. بالanatomy, during anatomy, if you got an AP view of the femur, you can see that the medial condyle of the femur is more projecting than the lateral in both flexion and extension طبعا. فبالاكستنشن احنا اللي راح نسويه هو distal cut. When we ask for the manufacturer, the assistant manufacturer will put it in 6. هذه 6 اللي قلنا عليها هنا اللي هي الانجل. And then the distal cut is 0. 0 معناها احنا 9 millimeter from the medial condyle of the femur. Okay, and this represents the width of the component, femoral component, later after we put the component inside. So that's why in this picture you can see number 3 اللي هو هذا distal femoral cut هنا 9 millimeter from the edge, lower edge of the medial condyle. So what about in valgus knee? INSAL suggested that whenever you have a valgus knee less than 20 degrees, make the valgus cut 6. More valgus requires 5 valgus cut. يعني احنا رح نخلي هسه ال 6 degree همينة تختلف. قلنا بالطوال بال 190 patients you have to make it 4. بالshort people you have to make the valgus angle 8. In valgus knee, not the varus, the valgus knee have got either if it was less than 20 degree valgus, you make the valgus cut 6 as that of the varus. More than 20, lower the valgus cut. Obese patient, usually with varus, make it 5 because من احنا اللي حنسوي الفالجس cut, they may have rubbed both knees if you are doing bilateral total knee or what we are called a staged operation in total knee. That's all what we have in the coronal femoral side. What about the tibia? The tibia here must be perpendicular to its mechanical axis. In the previous webinar, we suggested that the mechanical axis of the tibia is the same or it is parallel to that of the anatomic axis. هم اثنيناتهم from the center of the knee to the center of the ankle. وعرفنا احنا and we know that the center of the ankle مرات يستعملون soft tissue, but it is not very much indicative. واحنا عرفنا انه Patellar dome, which is the easiest one, the center of the Patellar dome to the center of the knee. So also the center of the knee from the medial and lateral plateaus, and you have got this point. فهذا البوينت إذا كان هو number 4, هذا number 1 اللي هو mechanical axis of the body, mechanical axis of the lower limb. Okay, so the number 4 is that the anatomic and mechanical axis as well. You know that in the previous webinar we said it is the knee joint in normal knee, it is not perpendicular to the anatomic mechanical axis because there are 3 degree varus. When we are applying a 3 degree varus in the cut of the proximal tibia, لأن إحنا رح نسوي الcut more varus like that of the anatomic knee, رح نشوف إحنا uneven load distribution, and then it will be not parallel with that of the femur, or maybe we may have an uneven load, and then there will be increase in the polyethylene wear and failure. So that's why we are cutting the proximal tibia perpendicular to its mechanical axis. You can see they are the anatomic and mechanical axis, they are parallel in figure A. In figure B, اللي هو هيكون عندنا deformity. Whenever there is a deformity, the anatomic axis will be different from that of the mechanical axis. And this is per se in another lecture how to treat with the extra articular deformities regarding the anatomical axis when it is different. So how about the rotation? Rotational alignment. This picture, it shows that inflection of the knee. This is not an extension. This is a flexion of the knee. Like the condyles of the hip, the intercondylar notch, and the sulcus is here. Now, you can see in the right side, the most right is the medial and the lateral here. You can also see that the medial condyle of the femur are projected more distally than the lateral, not always posterior. It's more distal, as well as that of the proximal tibia. The medial tibial plateau is lower than the lateral tibial plateau, and it's more concave. It is forming a 3-degree of inclination, and this will talk about the second code اللي هي كنا احنا مسميها 6 first code, and the second code is a 3. So in order to make the condylar cut, you will see how can we do it in order to get a flexion and extension gap together. The posterior medial condyle is projected, as we see, in posterior than the lateral, and the tibial surface is a 3-degree on its mechanical axis. So you have to put, this is the second code, اللي هي رقم 3, 3-degree of external rotation in the femoral implant. If you do, اللي هي هاي C الأخيرة. Why is that? Because if we cut the distal femur with that of the tibia اللي هو أصلاً 3-degree, there will be not, they are parallel, but they are inverse. If you cut the proximal tibia 90-degree and you cut the posterior condyle of the femur 3-degree, there will be trapezoidal shape. You have to get this rectangle. So that's why you have to put it in external rotation of the femur, as it will be parallel to the surface of the tibia, and we will know how. What are the references that we are using? All reference must be used, because one of them not reliable, not only one. 4. The first is that the trans-epicondylar axis اللي هو هسه هنا الواضح بين الميديال والlateral epicondyles. You can see, you can put your hand and then mark it with your, like for example, the electrodiathermy. The posterior condylar axis, which is here, اللي هو بين الميديال والlateral, and as we see that the medial is projecting more posterior than the lateral, and it forms a 3-degree of inclination between epicondylar, هذا الاكسس مال epicondylar وهذا الاكسس مال posterior condylar axis. The other one is that is the white side line. AP or white side line started from the lowest point of the sulcus to the upper part of the top of the notch, and it is perpendicular as average 91 degrees from the epicondylar axis. ناس شافوا من عندهم انه هي من 80 الى 110، ولهذا السبب احنا بنستعمل كل only one. You have to use every reference. Another thing is that the transverse axis. This transverse axis is parallel to that of the proximal tibial cut. So these are the 4. First one is the epicondylar axis, 3-degree in external rotation of the posterior condylar axis, and anteroposterior or the white side line, which is perpendicular to the epicondylar axis, and that of the resection of the tibial cut. So here in this picture, you can see that the native in the red, the native posterior condyle is a 3-degree valgus in relation to the mechanical axis. إذا احنا سوينا الميكانيكال axis مال التibia on a flexed knee, it will be in valgus. And the native tibial plateau in the purple, native tibial plateau is a 3-degree varus. So this is not, they are parallel, but they will be disconfigurated, not rectangular. So in order to make a rectangular distance true between the posterior condylar cut and the proximal tibial cut must be the external rotation of the component of the femur in relation to the trans-epicondyle axis. Is it true for every case? Of course it's not. Because if you have a hypoplasia of the lateral, for example, in a severe rheumatoid arthritis, or a congenital hypoplasia, it is not a 3, it will be 10. So the variation will be there. In varus, there will be an excessive external rotation, as you see this shade on the medial condyle, there will be an excessive. So you have to reduce it into 3 or 0. The valgus, you can see the shade of the lateral condyle, and it will be an internal rotation. So in cases of valgus less than 20, make the external rotation 5. And if it is more than 20, or severe hypoplasia or in severe rheumatoid with a patellar subluxation, because the patellar will be there, 7 degrees of external rotation in order to make this cut parallel to that of the proximal tibia. Another thing is that the anterior resection, وإن شاء الله رح نحكي بيها بالمحاضرة القادمة عن موضوع anterior referencing, is that what we call the grand piano sign. If you cut the anterior part of the resection, you can see that the medial is more than the lateral, which is projecting تقريبا 2 to 3, 3 to 2 شيء زين, which is named in the American Journal of Orthopedic in 2011, looks like that of the piano, which represents that it is an external rotation cut. So there are intraoperative tips. You can see intraoperatively this is the external rotation from the posterior condylar reference. And this is the white side line and trans-epicondylar axis. You can see now the posterior condyle here. Welcome. The posterior condyle on the medial is more cutted than the lateral in order to make this is an external rotation. So that's why when you put the extension, the cutting box of the external rotation, you have to ask the instrumental guy who put it in the pins into an external rotation in order to make the cut in the parallel with that of the proximal tibia. What about the tibia? There are rotation. Yes, because if you can see that the tibial tubercle is anatomically on the lateral side of the midline of the proximal tibia. يعني إذا شفنا إحنا هذه الصورة C, لنلاحظ أنه البوستيريور patellar tendon attachment with that of the tibial tuberosity, it tends to be more in lateral. So you have to take your mind, to put your mind, the tibial component, not the cut is rotated. The cut is perpendicular, almost. But you have to look for the tibial component, and we have many references. The first reference is that the tibial tuberosity is divided into three thirds. Between the medial and the middle, you can put the center of the tibial tray. لوش احنا سويناها. Why it happens? Because that the tibial tuberosity, you can see it tends to be on the lateral, not on the center of the axis. إذا احنا حطينا هسه هذا from the medial to the lateral, and this is perpendicular, you can see that the most posterior and most anterior is not attached with that of the tibial tuberosity. So the attachment of the tibial component will be just here in this point, اللي هي ممكن احنا نرسم annulation exactly here. Okay. So what about another reference? Annulation. Okay. There are other references regarding the tibial rotation, is that of the bimallular bimallular distance, you can see that the external with the some surgeon, they use an external tibial cutting jig. When you are using it, you can see that the intermallular distance, you can divide it into two, and the reference will be just at this point. Another reference is that the second ray of the foot. And remember, if you have a foot deformity, severe foot deformity, you cannot rely on this one. So you can rely on the tibial tuberosity. Some of the references suggested that the tibialis anterior, not the shin of the tibia, which is projecting just here, is another landmark for the rotation. So beware about foot deformity. So intraoperative covering of the, another thing is that the intraoperative covering of the posterolateral tibia is another thing. Now, this is an intraoperative picture. This is the tibial cutting box. And we can see here is the medial and there is the lateral with the patellar tendon. It looks like that the posterolateral were very well covered, while the uncovering, a little bit uncovering of the posteromedial. And this is why, because not overhanged, of course, but you have to put in your mind for an external rotation. As you can see anatomically, the posteromedial is also like that of the femur, is projecting more posteriorly than the that of the lateral, as you see in this picture. In the yellow line is larger than the green line. So please don't do internal rotation of the tibial components and internal rotation of the femoral component also together, because these components will affect the tibial tracking, and failure will be early. Increase the tendency of the lateral patellar subluxation and increase the Q angle, as you see in the next talk. So the sagittal, these are coronal. We talked about the rotational, and then now the sagittal alignment. With the coronal, we say the code is 7. With the rotational, the code is 3, and the sagittal, 6, 3, and the sagittal will be 7. Regarding the sagittal, 7 degree is the posterior slope of the tibial angle. It is built up because that of the tibia, if you took the anterior or the posterior cortex in the lateral X-ray of the tibia, you can see that with the perpendicular line here, you can see that with this from the uppermost into the lowermost, there will be an angle which is called the posterior slope angle. It is found that from 7 to 10. Most of them, they are 7. The system, the system that we are applying is that the total knee. Sometimes they have the cutting jig without a slope, like that of 0. So please put in your mind, when you are new in the total knee arthroplasty, you have to phone your company, the company guy, tell him to bring everything with him and make it on the sawbone first. Then see the same company, لأنه أكو هواية من الشركات قسم من عندها نسوي بالcutting box ويطلع قسم من عندهن 0, قسم من عندهن 3 and 7 and so on. Not only the slope, everything. هذا نفس الشركة تروح تشوفها مع another surgeon very well expert with this company and how to deal with this. And after that, you make it, inshallah, successfully with your patient. Very important to know that you can apply it in by hand, all right? So regarding the femur in the sagittal plane, نفس القصة اللي سويناها احنا بالcoronal. You can see that the sagittal plane anatomic line, another 2 points here, 2 points here, and then you can add this line which is the center of the medullary canal. Okay. إذا تشوفوا إنه هنا اللي حيكون from the Blumensaat line, it is away from few millimeters, and this point on the AP and lateral represent the entry point of the intramedullary guide اللي احنا حكيناه وكان هو 6 degree valgus. This is the entry point. This is from the intraoperative. I make this one by electrodiathermy, just anterior to the tip of the top of the notch. لأنه البلومنسات line هي top of the notch اللي هي from anteriorly. Okay, and then you add this area اللي هي خلينا نقول 0.5 millimeter, and it is just on the medial side more than the lateral. Okay, لأنه هذا هو اللي حيقودك إلى الاتجاه الصحيح of the femoral and tibial component as well. What if we have an increase in the slope regarding the tibia? If you increase the slope, for example, you dig it more posterior, there will be tight in extension. The patient cannot extend the knee, which means that it is a fixed flexion deformity. And if he has got a flexion, there will be an increase in flexion gap and unstable or loose in flexion. واحنا ان شاء الله بالاوبراتيف تكنيك رح نحكي على الجاب gap balancing and gap imbalancing and how to solve it. What about to reduce the slope? For example, if you don't make the slope or make it reverse, tight in flexion, because the slope is now posteriorly bulged with that of the posterior condyle of the femur, a recurvatum during standing, and be careful about the last, because the anterior tibial cortex is very weak. There may be subsidence of the tibial tray. يعني مجرد شغلات بسيطة ممكن أنه لا سمح الله توقعنا في مشاكل. Okay, now you can see this is the anatomical line on the lateral x-ray, the femur. It must be perpendicular to that of the cut. And here we are going to have the, welcome. You are now see the post-operative, and it is also perpendicular. So what about if we got this one is more anterior or more posterior? What would happen? Let's see. This is the entry point. If it is more proud anteriorly, there will be an extended component, reduce the flexion and recurvatum. Extension, recurvatum in the same thing, and you have got a reduced inflection because the posterior condyle is extended. What about if it is posterior, a flex component, لأنه posterior condyle حيروح more posteriorly, reduce in extension, and the tight in extension and fixed flexion deformity. Then we have the patellofemoral joint. Don't forget about the patellofemoral joint, because we are dealt with the alignment of the hip of the femur and the knee. We can also adjust the patellofemoral joint. Remember that there is what we call the Q angle, which is formed from the ASIS into the center of the patella and the midline. Okay, and this is increased in female because of gynecoid pelvis, and the force هي هذه الكيو angle جايه من كلمه quadriceps. The force that tend to subluxate the patella into the lateral vector. So do medial location of the patellar component في حالة إذا إحنا نريد نسوي resurfacing of the patella، وإن شاء الله رح نحكي بتفاصيل عديدة عن موضوع إنه patella resurfacing versus not. So the patellofemoral joint, what affects it? First of all is that the internal rotation, which we say don't do it. External rotation of the femoral component. You see that the internal rotation of the femoral component, وده تشوفون هاي النقطة هي المكان مال الباتيلا, it will be subluxed. So don't internal rotate the femur and the tibial component as well. The tibial component here, if you can see that this is the tibial tubercle, and there will be we put the center of the tibia, and now you can see that this is between the medial and middle tibial tubercle. If you do the rotation, internal rotation of the tibia, there will be an slip of the lateral patellar tendon. Another thing is that do not medialize both the femur and the tibia. Usually put it on the lateral in order to make it tracking very well. So these are the don'ts. The last thing is that the joint line. However, the joint line is a very big entity about the joint revision surgery, but you have to see that especially in the primary knee. So you have to make it very well accurate. The joint line simple words انه احنا عندنا محاضره كبيره جدا عن الجوينت لاين بالريفيجن سيرجري ان شاء الله راح تكون عن why we have to take the joint line exactly. First of all, how to find it. It is 10 millimeter and plus minus 3 with a standard deviation طبعا عالي اللي from the lower part of the patella. It is 1 cm or 1.5 cm from the fibular head with minus 5, and you can see how here the fibular head is not always perfectly on the joint line, but if you have a medial and lateral epicondylar axis, the medial epicondylar distance, it's from the joint line 30 and 26 millimeter respectively. خصوصا من انت بدك تريد تسوي surgery and you have got, especially in revision, except in major revision surgery, you can find these landmarks اللي هي الميديال والlateral epicondyle. Larger defect can apply both condyles and less a major defect as we see. القصة هي كلها عبارة عن انه احنا if we raise the joint line not reduced, because reduction will cause a severe failure in the tibia. If you raise it more than 8, many figures, many literature suggest this figure 8 is not to over it, because there will be a reduction in the range of motion, impaired patellar function like BAHA, patellar clunk syndrome, the mid-flexion instability, reduce in extensor strength, and worse the knee score. I'm very thankful for your patience and for your listening. Thank you all, and I now change into the questions. Thank you very much. Anyone have a comment, please just raise a hand and I will open the mic. Okay, there is a question from Nabrad Amin. Regarding the tibial slope, according to what we can choose the slope either 0, 3, or 7 degrees? This is a very nice question, Dr. Nabrad. Actually, first of all, I depend on the templating first. Template is very important because this will guide me whether to slope the angle of the native joint line. This is the first. The second thing is that I refer to the company manufacturer slope angle. If you have got 3 or 5 degrees, you can choose 7. It is forgiving. But if you can see that the native tibia is 0, you cannot choose 10 degrees in a slope angle, because this is a very major mistake. Don't make it more than plus 4 degrees of the change of the slope. This is a very beautiful article. You can see it in Parvizi, and many literature has suggested that plus 4 degrees of posterior slope, if it is increased, you may have a failures. Okay, thank you. Dr. Mahmoud. أهلا وسهلا أستاذ محمود. I'm very happy to be with you and to be with us. Hello أستاذ، شلونك؟
هلا وعيني دكتور سنان، شلونك؟ شلون صحتك؟
الله يخليك، الله يبارك فيك.
أحوالك أمورك؟
الحمد لله الحمد لله.
سلام للشباب كلهم. أنا استمعت جزء من المحاضرة حقيقة كلش حلوة، بس حقيقة المعلومات كلش مكثفة دكتور سنان. وأنا كنت أتمنى وياها الصور لو كان يعني عملية أو خطوط بيانية حتى يعرفون.
هو أستاذ اللي أنا سويته شنو هو اليوم يعني انطيت المحاضرة about the alignment.
إيه alignment وعندك الابروتش.
simple way in approach، يعني ما اختاريت هواي اشياء من عنده، لكن بالنسبه للالاينمنت استاذ انا حسويها هم يعني بعد المحاضره الثانيه حتكون about the operative technique.
ايه يعني هي هاي القصد ولا هذا، بس بالسؤالي بالابروتش السمبل واي هي انه حتى لا يصير هو الستاندرد الميديال parapatellar، وعندنا lateral لما يكون contracted patella.
يس
contracted patella روح على lateral. الاذر ستاندرد تروح medial. عندك الام اي اس الثلاثه. الام اي اس يا اما ميد فاستس
حكيناها استاذ، ميد فاستس، سب فاستس اند
او كوادرسبس سبيرنج.
سبيرنج يس
كوادرسبس سبيرنج هذول. عندنا الاكستندد ابروتش اللي هو
كوادرسبس سنيب يس
سناب وتيبيال تيبروستي
والتيبيال تبروسيتي ريسكشن.
بالضبط هذول الابروتش اللي عندنا. بالريفيجن يعني بالريفيجن اكو مثلا السكارز، اذا عندك مالتيبل سكار جو تو ذا لاترال وان، حاول 6 سنتيمتر رول بيناتها. ليتس حاول تنشن بالفي شيب يكون يو شيب.
حكيناها استاذ هاي اليو ساين اند في ساين حكيناها اللي قدام استاذ.
بالضبط هذول لين يعني حقيقه بالنسبه للهوبات البحوث اللي صدرت يقول لك اذا انت ما تشيله النيرف انجري يو بريزيرف ات and vessels الفيسلز also preserve it.
يس
لكن الباك جراوند هذا بيها انه لاترالي يكون صعبه تيجي تخلي السباين وتروح له.
صحيح.
لانه اذا قدامك الهوبات تريد تروح لاترالي
هو استاذ المشكله
باللاترال.
Yes sir. There will be a problem, technical problem when you are using an external or internal jig of the tibia. ولهذا انه قسم من literature they suggested that to remove the patellar fat pad, only the inferior part of the patellar tendon, and preserve the inferior pole of the patella with the patellar tendon. يعني هي هنا بس هذا المكان اللي هم اكدوا عليه انه you preserve it in order to reduce the pain as well.
بالضبط. البين النيرف اندنج والبليدنج، ترى البليدنج اكثرها تيجي من الهوبات. واي بليدنج تجي بيها فجينيكوليت فيسل، ولهذا قسم يخلون وقسم ما يخلون. This is a philosophy. يعني تريد انت يعني ما تريد demanding surgery قصه you need demanding surgery لا يعني تقدر تخليها. فبالنسبه للافراد هسه انا وياك اخاف عندهم احد اسئله ولهذا نقدر نتعاون ونجاوب.
دكتور محمد قحطان he is دكتور احمد لطيف. welcome sir.
السلام عليكم.
اهلا
السلام ورحمه الله وبركاته حبيبي دكتور.
مرحبا استاذ، شلون الصحه؟
حبيبي هلا دكتور احمد الورد. هلا وعليك.
الله يخليك، شكرا جزيلا دكتور سنان على المحاضره الحلوه.
I'm thankful for your coming.
الله يخليك. بس عندي سؤال للاستاذ محمود اذا امكن.
يس سر.
تفضل حبيبي.
استاذ تذكر واحده من مناقشات البحوث اللي طالب بورد من مركز التدريب باربيل سوي بحث بخصوص removal versus retention of fat pad, hover fat pad in total knee. يعني the final decision انه هو the hover pad is very important to remove it because it's prevent the future degeneration of the patellar tendon. يعني قسم من الستدي اللي قال انه if you remove the fat pad you may end with the late degeneration of the patellar tendon. So it is very important for lubrication and vascularization of the patellar tendon. So you retention or you remove it.
استاذ احمد حقيقه هذا طالب مالي دكتور احمد هسه اللي هو مدير مستشفى ضاري هسه الدكتور احمد يمكن دكتور وسام العفو دكتور وسام. هذا البحث مالي أنا سويته. فإذا أنا دكتور وسام سوينا ريتنشن أو فيرسس يعني ما أدري إذا أبو أربيل هم مسوي ما أعرف أنا، بس هذا سويته طالب مالي وسام قبل سنتين ثلاثة. هي الأيديا is better to leave it الهوبات better to leave it لأنه
just respect what minimal amount just interfere with the viewing.
شلون حبيبي شلون استاذ احمد؟
or only resect the small amount that interferes with your viewing
بالضبط. your viewing بالضبط. وهذا اللي اريد اقوله انه حتى بس تقدر تخلي السبايكه حتى تسهل تفوت لانه يعني ريلي شوي ديماندينج اذا هوبات قدامك. فاتس بيتر تو لانه حقيقه فور نيرف لانه لو تعرف اكثريتهم مرات يجون باراستيزيا اراوند ذا ني يجون يقول دكتور خدر عندنا ومر نفس الوقت بليدنج هواي يصير اذا تشيله. فبيتر تو let it without touching it just minimal amount to do spike. فأنا with you يعني 100%.
Okay, أستاذ أفيدك. السؤال الثاني, if you have a defect on the medial tibial plateau, small defect, and you don't want to change to stem type, primary stem type, and you have a defect more than 5 millimeter, okay?
You are doing primary. You are doing primary.
Yeah, primary. Yeah, you are doing primary, and you don't want to put a stem tibial type. And you just want to put the just LBS one without stem.
Yes.
And you have a defect on the medial tibial plateau.
Yes.
Of more than 5 millimeter. So do you agree that use a trick like lateralization of the tibial component, cement screw of the defect? What's your trick, please?
Three philosophy in this aspect, Dr. Ahmed. You can do it in three يعني solution. First, either from the cut of the femoral distal cut or for the tibia lateral cut, put it and put screw above it cement. This is first. Second,
so bone graft cement
you
and
can
screw.
screw to the bone. يعني تاخذ الديستال اللي قصيته مال الفيمر او lateral femur tibial condyle lateral side.
You mean, sir, you augmented with the bone graft?
Bone graft with screw.
Yeah.
وتغطيه شويه بون او تاخذ البون سمنت and to screw with it. بس السكرو لا تطمسه بالبون سمنت.
Yes.
يعني يبقى الهيد of the screw and under it.
نعم. استاذ محمود تسمعنا؟
الو.
يمكن استاذ محمود انقطع عند النت. اوكي دكتور احمد، اعتقد
يعني
دكتور استاذ محمود اجى مطلخ بس يمكن بدون صوت. I think that it is augmented with the bone graft, yes.
And there is also, I think there is another two trick, is to lateralize a little bit, lateralize the tibial implant to not make it more medially, make it more laterally, little bit. And I think so to undersize the tibial component, so to prevent overhang and prevent medial compression. I think this is additional true trick. دكتور أو أستاذ محمود يعني اتفقوا وياي؟
Yes.
محمود تتفقوا وياي؟
Yes. This is correct. Okay. يعني مرات ما عندك الستم، يعني ما عندك LCK. فيو can do this option. لأنه الهانجينج هي الأندرهانجينج يعني خليها ببالك is better than overhanging. يعني التيبيا لأن يصير overhanging MCL يصير rotation وراح يصير pain medially. فit's better not cause a rotation of the MCL. لهذا هاي الطرق تقدر تسويها ويا البون سمنت bone graft, bone cement with a screw or just bone cement, and you apply LPS. Don't worry.
Yes, sir.
شكرا جزيلا استاذ محمود. شكرا جزيلا استاذ محمود.
العفو.
شكرا دكتور
استاذ احمد.
ممنون دكتور
شكرا
احمد.
جزيلا.
يعني عمي احمد هي الفكره it's very well done with when you are downsize the tibial tray you have to put it on the lateral. الفكره من عندها هي همين اللي حنحكيها بالاوبراتيف تكنيك. The tibial tray must be set on a cortical bone, not on the trabeculae, because there is weakness in the trabeculae inside the proximal tibia. So when you have a good strength in the lateral cortex and medial cortex as well, that can well fitted, that's where you can put the tray to sit inside the proximal tibia. Otherwise, if you are going to do a downsizing, for example, to take a lower size, you have to put it in the lateral in order to make it stronger enough to bear the load and distribute the load well.
Agree with you. With you. Thanks.
Thank you very much.
شكرا جزيلا.
There is another comment, Dr. Mohammed Qahtan. He's commenting on the posterior slope. He said that we can use the contralateral knee as a reference for the tibial slope angle regarding the slope if it is 0, 3, 5, or 7. There are many manufacturers, as we said, and yes, the contralateral knee as a reference for in order to maintain the normal slope angle very operatively.
دكتور سنان
Yeah.
تسمعني؟
Yes, sir.
اللي هو السلوب ليش صار اختلاف بين الكومبانيز مثلا زمر 7 سترايكر 5 جي ان جي 5 واكو سمول كانتريس يسوي 3 هي حقيقه سووا بحوث على نيتيف ني اناتوميكال فطلعوا هذا الريزلت بانه most of the patients has a slope between 5 and 7 يعني more خلينا نقول 90% 10% out of the layer ولهذا بين الخمسة والسبعة على اختلاف الشركات انت ماكو اختلاف لانه this is the anatomy لانه آلاف المرضى قاسوا السلوب طلع هذه ف this is not problem 5 7 حسب الشركة اللي عندك بس تحاول not more than that وبالريفيجن لا تستعمل سلوب لان انت you already cut the slope فبالريفيجن زيرو.
Yes.
Yes.
Any more questions or comments? If you want to raise your hand and comment in voice, we are happy to. Okay, I hope that it is a very long lecture, I think. However, I think you are enjoying now and see you in the next webinar. Dr. Mahmoud Shahab, we will meet you in the next webinar, inshallah.
Yes, painful knee. راح يكون painful knee.
All right.
الأسبوع القادم. Algorithm, how you deal with the painful knee.
Okay.
والأسبوع اللي ورا راح يصير على principles of revision knee. يعني فيديو ومحاضرة كل step by step. الأسبوع القادم راح تصير painful knee.
Okay, اللي حتكون همي أنا at Friday and we will
continue.
Yes,
Friday. يعني I am sorry قلت لك webinar.
إيه تمام.
غير webinar.
I
am sorry for this.
لا it's okay. وإن شاء الله حيكون السبت الويبينار الثاني الرابع مالتنا راح يكون about the operative technique in total knee replacement. Thank you very much for your attendance and have a good day. Thank you very much.
Thank you.
Thank you, sir.
Hello.
One last I came late. Okay. لا هو anyone came late I will record this and if any questions for you you can write it to me. Thank you very much. Have a nice day.